for me as a primary care doctor, one of the things that is striking is it's making me, once again, and with vigor this time, it's making me question why we take care of people the way we do. So I've been in, as you know, as you heard, I've been working in technology for many years and in healthcare, and it's always been amazing to me that we get people to come to a medical center to get checked on for a 10-minute visit when we could easily do this remotely. We have the technology to do this. Now, today we don't get paid for that in the same way, but if you think about the number of patients that we see in the office that we could take care of remotely in some way, it's astounding. And we've got to think about this because we're talking about limited resources, which we've always had, but it's even more so now, limited resources in healthcare organizations and physicians and nurses and so on. And we have people coming in for things that they don't need to come in for. So they're exposing themselves to a risk.
This time on the Plutopia News Network, Dr. Danny Sands joins Jon and Scoop in the virtual studio. Dr. Sands is co-founder of the Society for Participatory Medicine, a private practitioner and specialist in medical informatics. We explore how technology has changed the way medical practices deal with patients, their data, and much more.
This is the Plutopia News Network. You can find us on Twitter as @Plutopia and on Facebook as Plutopia News Network. We interview interesting people with compelling ideas, such as today's guest. Today we're talking to Danny Sands, a physician who's worked in a variety of capacities in the healthcare IT industry for over 25 years. Danny is passionate about and dedicated to healthcare transformation. Danny holds an academic appointment at Harvard Medical School and maintains a primary care practice at Beth Israel Deaconess Medical Center, in which he makes extensive use of health IT, much of which he helped to introduce. I met Danny through the late visionary Dr. Tom Ferguson, who dedicated himself to participatory medicine, defined as a movement where networked patients shift from being mere passengers to responsible drivers of their health, and in which providers encourage and value them as full partners. Danny and I were among the co-founders of the Society for Participatory Medicine. So thanks for joining us, Danny. Participatory medicine, I think, is a good place to start. How has the patient's role in medicine changed since you and the others who collaborated with Tom on a vision for e-patients? What have we seen over the last, say, decade or so?
Yeah, great question. It's a pleasure to be here with you, Jon.
Thank you.
Participatory medicine has changed, I think, not as much as I would have hoped that it would have changed by now. But I think what we're seeing is we're seeing many patients become more savvy about the fact that they can utilize technology to help them in their care. In my own career, I initially set out in the medical informatics space because I wanted to create better tools for clinicians, to empower clinicians with information technology. But I observed that patients could be just as empowered, even more so, by information technologies. And that led to my introducing email with patients into my own practice, which this was back in the early 90s, and people thought I was crazy. But what we've seen now is that, at least in the United States, patient portals have become much more ubiquitous. And in part, I think that's been driven by the meaningful use rules that were introduced. So, financial incentives make things happen. And so, many practices, probably most practices at this point, have a patient portal. Now, it may be terrible, but they do have the patient portal, which means they're allowing for online communication. They're allowing patients to have access to at least their test results. The other thing that's happened, I think, is that we've seen that tens of millions of people throughout the U.S. Have access to their notes now through their patient portals. And that's through an initiative that came actually from my institution, something called Open Notes. And that has been really terrific to see as well. I think that with successive generations of patients, they're they're expecting more of their healthcare system. That is, that I think that they're viewing healthcare more as something that is something where they can demand convenience. They view themselves as consumers more often, and I think that that's also a positive move. But I think we're still limited, John, and still we have practices that don't want patients to take their health information with them. We have physicians who are uncomfortable with this. We have physicians who don't respond to messages from patients, and so I think we clearly have a long way to go, but we've made progress.
Well, I mean, there's clearly an issue where a patient may be exposed to information that they absolutely don't understand, and a physician may have to take more time, sometimes maybe frustratingly more time, to try to help the patient understand the meaning of the information that they're seeing. Isn't that correct? I mean, isn't it inherent that physicians are going to feel a little resistant to that scenario?
Yeah, you bring up an interesting point, which is that if we let patients see their information more, then they may generate more questions, and somebody's got to answer those questions. I think in practice, we haven't seen a lot of that, John. I think that has been one of the concerns about even letting patients see their test results online, that we're going to get barraged with phone calls to ask us about meaningless abnormalities in blood tests, for example. And yes, I think there are some patients who are doing that, but I think many patients, most patients are not, and most physicians haven't seen an increase in phone calls for that reason.
Well, with the advent of HIPAA, when that was beginning to be implemented around the country, the concerns about security and privacy weren't nearly as strident as they are today. How would you characterize the change from the early days of, say, HIPAA to today, when there's so much emphasis on security and privacy?
Yeah, that's an interesting question, too. And I think that too frequently health systems have been using HIPAA as a way to prevent patients or people taking care of them to have access to records. So we've got a situation in which, and this just happened to me the other day in my practice, I requested a patient's record, a patient who was seen in an emergency department somewhere, and I had my assistant call, and the response we got back was, "Oh, you can't see that. You've got to have a patient sign a form to release that." But in fact, that goes to one of the misunderstandings about HIPAA, which is that HIPAA has always allowed access to records so that care can take place. So in other words, if you were seen in an emergency room, Scoop, I should be as another one of your healthcare professionals. If I'm taking care of you, I should be able to get those records without you having to sign a consent. Likewise, HIPAA and the revision to HIPAA since HIPAA came out made it very clear that patients do have access to their records. And again, although health systems have made it difficult for patients to get their records frequently, it is clear in the law, and there's a part of the government that actually exists to make sure patients can get their records, even though health systems often want to block it. Now, what's interesting is that, and this isn't something that was a thing when HIPAA came out, is that you should be able to get your records in an electronic form if that's what you want. As now we have, not quite all, but most of your healthcare is now documented in electronic medical records, which wasn't the case back in 1995. So the information is electronic. So you as a patient now, and this has been clarified, you should be able to request this in electronic form. And in fact, just this week, just yesterday, Health and Human Services has put in place, and I haven't reviewed the entire final rule, policies about to prevent information blocking, so that institutions can't block you from getting that information. And ultimately, what that will do is it will open up new opportunities for companies that are offering services and apps and things like that. It'll make it easier for them to get access to your records with appropriate security safeguards. But that's going to ultimately help you. To be sure, there are privacy issues that we've got to deal with at the same time. So HIPAA's not being lifted in some way here, but this will need to sort itself out over time. The fact is that if you want access to your records, or you have an app that you want that app to have access to your records, that should be permissible, and we shouldn't have to use other weird techniques to try to work around the difficulty of accessing the information. For example, I am the chief medical officer of a really interesting company called Backpack Health. And one of the things we do is we make it easy for patients and caregivers, particularly patients who have complex and rare diseases, to access their health records in any way we can. So any way we can help you get your information or enter it in some way, we'll do that. And we help you manage that information. We help you share it securely and so on. But companies like Backpack have had to do workarounds because we have such a broken system of interoperability. And hopefully that will change now that this new rule has been finalized.
Is this rule going to drive the evolution of like standard protocols? Or standard formats, for data?
I think that and again, I haven't been able to read through the rule yet. I haven't had time since it just passed yesterday. But my understanding is that the rule is going to insist that we use FHIR for health information exchange. That's fast healthcare interoperability. I forget what the R is, but FHIR for information exchange. Now, that is helpful, but it doesn't actually stipulate the way in which that information is encoded. And so that's still something that an extra step there. In other words, it's sort of dictating the kind of plug you put in the wall, but not what the kind of current is that comes through that plug.
Yeah, I found that fast healthcare interoperability resources.
Thank you, resources. I always forget that one.
And this says it's a standard describing data formats and elements known as resources and an application programming interface for exchanging electronic health records. So it sounds like the API would be key here for interoperability.
Yeah, that's right.
So who is developing that?
It's done by a consortium. It's actually from the organization HL7. They've taken that over.
I'm recalling, and I know you probably recall this too, that our mutual friend and colleague, e-patient Dave DeBronkart, tried sharing his data with an app
Google
or
Health.
having an app address. It was Google Health, right?
Yeah.
And he said everything was wrong in there.
Yeah.
Much of what he was seeing was incorrect. So the intention was there to have interoperability, and there was an API in the healthcare system that allowed access, but somewhere between the healthcare system and Google Health, there was a disconnect.
It was actually worse than that, John, because the health system in that situation could send whatever they deemed appropriate. And so they chose to send things that were inappropriate, such as billing codes rather than clinical information. And, unfortunately, the way we do billing often depends upon billing codes. And those billing codes or diagnosis codes are used for billing purposes, but they're not used for clinical purposes. So there's a real mismatch there. And so what Dave was seeing in his record were things that he didn't have, but the person ordering a test at some point thought he might have had, or, somebody he was seeing for a visit thought he might have had something. And so that led to a whole bunch of problems and inaccuracy. And of course, we know that Google Health doesn't exist anymore, but it wasn't actually Google Health's problem. It was the health system's problem that was just trying to say, oh yeah, we're going to let you get your data, but they were actually kind of disingenuous there because they weren't allowing access to the clinical data.
And I guess we have the same problem here that we've always had with the internet, which is to the extent that you want to be open and interoperable, you do have security issues, and those have to be addressed, and they can be hard to address if you really want to have true interoperability.
That's absolutely right. And, to be honest with you, I've been working in the healthcare informatics space for longer than I care to admit, over a quarter century. And, every time I would talk about this somewhere, people would say, oh, yeah, but what about the security of that information? And one of my mentors, the late Warner Slack, who, by the way, I think he was the person who introduced me to Tom Ferguson. But Warner Slack, a professor at Harvard Medical School, he said, you know what, no one has ever died from the inappropriate release of clinical information. But lots of people have died because clinicians didn't have access to that information. And I think that's what's important to keep in mind. And another way of thinking about that in today's environment is that, when someone is desperately ill, they don't really care who gets to see that information. They just want to get their care. They want to get treated, right? But if it's an ordinary person who's not desperately ill and they may have things that they're more embarrassed about, whatever, I understand that. And I'm not saying, I don't want our listeners to construe us as saying this is, we don't need any security. We obviously need security. It's very, very important. But I think it's important that there's a balance between access and security, particularly access by clinicians or access by the patient.
So as long as I've known you, you've had a practice, an ongoing practice. And at the same time, you've always worked with these various companies like Backpack. How do you find enough hours? I mean, how do you manage to balance all of that? And do you find that continuing to have your practice is essential to the other work that you're doing with like informatics?
Yeah. So honestly, since I finished my residency and I did my fellowship at Beth Israel in Boston and Harvard Medical School, I was doing my informatics training, and while I was doing that, I was spending most of my time doing informatics and part of my time seeing patients. So the actual truth of the matter, John, is that I have not been a full-time clinician since I left residency. And what I have found, and I found this very early on when I was developing clinical systems at Beth Israel, back even in the 90s, is that if I were just a technologist, if I were simply spending time, writing code or developing systems for clinicians, but I wasn't a clinician myself, I would not do as good a job. But having a foot in both camps, being able to speak clinician and to represent the needs of clinicians and understand innately the needs of clinicians, as well as understanding, the engineering, computer science side, I think it makes me better at creating clinical systems that are actually useful to clinicians. So I think that last thing you said is absolutely right, is that by seeing patients part of my time, it's helping me with my work with health information technology, whether it was at Beth Israel, developing systems that were used there, or out, working with the various companies doing work in that space. So in terms of time, I think that I don't work full time as a clinician. And so, I do that part time, and I think it's important. And by the way, I know this is an unpopular thing to say, or it's an uncommon thing to say. I actually like being a primary care doctor. Primary care doctors get dissed all the time. What's the value of primary care, and we're not paid very much, and all this. These things come up, and it seems like society cares a lot more about the high paid specialists. But, and we're seeing, burnout in record numbers among physicians. And, primary care is one of the fields that's definitely the case. And by the way, record numbers of suicides. But I think primary care, and there are many of my colleagues who do, find it very fulfilling. I think it's very challenging these days to be a primary care physician. I enjoy it. I would probably be a lot more frustrated with it if I had to do it full time, but doing it about half time as I am, I find it manageable, and I find that I can be the kind of doctor that I want to be to my patients, and I can find joy in my practice, and maintain my own sanity and maintain my centeredness. I think it is a privilege to be a physician, particularly a primary care physician, as complicated and as underpaid as that is today.
The primary care physician in Texas is an endangered species. In fact, medical care in many counties is non-existent. There are many counties in Texas that have no hospital and no clinic. You have to travel maybe 100 miles to see a doctor. Is this something that you see elsewhere in the country?
Yeah, Scoop, you bring up a really interesting point, which is that we have a tremendous healthcare system, but not evenly distributed. Like the famous statement about the future. The future is here, it's just not evenly distributed. Who said that, John?
William Gibson.
Thank you, William Gibson. So it's like that with the healthcare system. I mean, if you go to, Boston, I mean, it's, one of the best healthcare systems in the world, if you just take Boston. But as we move around this country and we have a real unequal distribution of resources, and as you said, Scoop, we have parts of this country where, there are no doctors. And there are many parts of the country where there are no good doctors and no decent hospitals. And that is a huge problem for us as a country. And to extend that a little bit more, there are parts of the country where, you could trip over cardiologists on the street, but they don't have a culture of primary care. And we know that in places where there is not a culture of primary care, that healthcare costs more. Healthcare is less satisfying. We're not getting best outcomes. Primary care is really important. So we've got to figure out how to fix this system, because and just to make this very real, I'm in a big academic practice, and we have patients who are moving all the time, all over the country, and often we'll send a message to all our colleagues saying, "Oh, I have a patient who's moving to such and such a city in such and such a state. Anyone know any good doctors there?" And so many of these places are medical wastelands. And it's a tremendous problem, particularly as people need to live there. They need to retire there. I mean, think about it. In your retirement years, you're moving to a place where there's no medical care for 100 miles or very poor medical care near you. That's a real problem.
Is anybody, or is there any organization or department or whatever that's charged with addressing this problem of distribution?
That's a really good question, and I don't know the answer to that, John.
Certainly a nice research topic.
Yeah, it's a good research. I think the Public Health Service probably has some role. There's something in Health and Human Services tries to concern themselves with that, but there's only so much you can do. One of the things they do is they try to, give people loans if they're willing to work in underserved areas. That is medical students as they're training. If you're willing to do service in an underserved area, then you get your loan. And that's a good kind of program.
That.
Yeah, it's a problem.
That television show, Northern Exposure?
Exactly.
Where Dr. Fleischman was, they paid him I guess they paid for his medical school in exchange for him to agree to work at this little town in Alaska for some number of years.
Yeah, that was a great show. I love that. And that's exactly what happens.
So shifting gears a little bit, I mentioned in the intro that, that you and I had met through Dr. Tom Ferguson, and that Tom was an advocate for what we have come to call participatory medicine. And just wanted to ask you about sort of how you got plugged in with Tom and how your involvement with participatory medicine started and evolved to where it is now.
So as I was mentioning, I pursued clinical informatics because I had this background in technology even before I went to medical school, not deep, but very interested in it. And I knew I wanted to do something in that space. And I was shocked that as I'm going through my medical training, that we were not taking advantage of information and communication technology to improve the care we were delivering to patients. So that motivated me to do training because I wanted to create a training in clinical informatics because I wanted to create tools for clinicians to empower them. But in my own practice, I was discovering that these tools were equally empowering to patients and caregivers. So I found that first through the use of email, and in 1998, I can't believe how long ago that was. 1998, I co-authored the very first guidelines on how to use email in patient care. And then in 2000, I helped create one of the nation's first patient portals at Beth Israel, still in use today. And somewhere along the line, I became acquainted with Tom Ferguson, and I think it was actually through my mentor, Warner Slack, I think. He introduced us. But either Tom found it independently or we met through Warner Slack, and Tom brought me into this group of crazy people that were getting together and talking about how healthcare could be different. And I'm saying crazy people advisedly because you were one of them, Jon. And we had a group of about 12 people who Tom brought together, and then he had sort of people rotating in and out. And we'd get together each year for a long weekend, and we'd talk about what we were doing to make healthcare better and what we were planning on doing over the next year, and sharing ideas and cross-fertilizing. It was fantastic. So that, really just lit things on fire for me. And that made me really continue to push in these areas. And so that led this, after Tom's death in 2006, we finished a white paper that he had been working on under a grant from the Robert Wood Johnson Foundation. And then in 2009, this group formed the Society for Participatory Medicine. And in my own, and I've remained involved in the leadership of this organization since the very beginning, for a long time as president, now as co-chair. But my own career, has always been kind of in that space. So, when I left full-time work at Beth Israel, although at the end I was doing things like working on the patient portal, I was really interested in working with companies that were interested in changing the way that we think about healthcare and changing the patient's role and how we use technology to empower patients. So that's really been my career trajectory in that space. I still find it really fascinating. I still think there's so much that we're going to be able to do.
I remember that we had a discussion early on, sort of as, I think this was while we were involved with trying to come up with a definition and in the process of founding the organization, and talking about how e-patient was being interpreted as like electronic patient or connected patient in that way. And no, it should be interpreted as empowered patient, because a patient can be empowered in many ways. And it just happens that, Tom's thing was that when the internet sort of appeared and he discovered that, which is how he and I met, he saw the potential immediately. And he had been doing a lot of work in what he referred to as medical self-care, and published a magazine. And really it was about how patients can do a lot more than they probably are doing to take care of themselves. There we are.
This is the very first edition of Medical Self-Care. I know your listeners can't see it, but this is it in my hand. I happen to come across it.
Oh, that's great. That's great. I wish I had a copy of that. And that's actually how I met Tom. He was speaking to the local Writers League about his magazine, and we made our connection that night. And when the internet became more of a thing, and I was really involved with it through Electronic Frontier Foundation and so forth, he sought me out, and we started having conversations about the potential for the internet, particularly to create a platform that would serve patients and that would give patients a way, in part, to research their own conditions and care, and also to compare notes, to come together in online communities and talk to each other and share about their particular conditions, which also could potentially become a source of a wealth of knowledge that would never emerge from physician research alone. That's right. So that's kind of the way I saw Tom's focus at the time, and I think that it's exciting that we were able to form the society. And at the same, I'll just mention that when we formed the Society for Participatory Medicine, it was kind of like we needed a container for this journal that we wanted to have, Journal of Participatory Medicine. And the journal was going to publish research about these things that we're talking about because there was no real context for that elsewhere. And I'm fascinated with the fact that you have stayed involved as a leader of the organization for so long. And what's the state of the organization now? It seems to have grown quite a bit and to have involved a lot of patients, a lot of very smart patients. Yeah, you're right. And just to go back to the term e-patients, Tom defined e-patients not as electronic, but he says e-patients are engaged, educated, enlightened, empowered. So that's what was Tom's big thing. And I think that the organization, starting from zero in 2009, has grown, not as much as I'd like, because I'm always impatient, but we have about 500 members around the world, which is kind of interesting. And the majority of them would call themselves patients. And some of, a good size chunk are also healthcare professionals of various kinds. There are other sorts of people. We have healthcare educators and researchers and other people who touch healthcare, a lot of caregivers as well. The organization has really had an influence on public policy in the U.S., which has been very exciting. We've had several conferences that have been very successful to date. We just recently, we published a manifesto, and we're working on a distribution plan for this, but this is a participatory medicine manifesto. And this was really a participatory project. So what happened is that we had an exercise at our conference in the fall of 2018, where we had, it was really an exercise where we had different questions would come up and people would write things on sticky notes and would run them up to the front of the room, and we had a moderator and all this stuff going on. In the end, I think there were 1,000 sticky notes, 1,000 Post-it notes with different ideas on them. And then a group of people went through all of this information and put it in buckets and so on. And then evolved, with a lot of external additional input, evolved a series of I will statements from different perspectives. So in other words, if you're a patient, you say, I will do this. I will learn about my illness. I will, do this and that. If you're a clinician, I will explain things in a way that a patient understands. And it's really a very powerful piece, I think. And if your readers or your listeners want to read more about that, you go to participatorymedicine.org, which is our website, /manifesto. But anyhow, that's been an exciting new project as well. And I think it's an exciting time for the organization. We're really trying to
improve our foundation. We're working now on improving the governance structures that we have. We're shoring up our finances. We're in the process of hiring consultants so that we can actually do some of this stuff, and then ultimately hire professional staff. So there's a lot of stuff going on under the covers that most members don't see. But on the member side, we have these conferences, we have webinars periodically, we have virtual town hall meetings that people can participate in, and our members also connect with one another on Connect, which is connect.participatorymedicine.org, which is our online forum that you and I have spoken about. And that's exciting too, because if you look at the types of discussions that are going on there, it's really cool. There are a lot of really interesting topics that come up, and a lot of resources, a lot of ideas come out of that. So I think.
And the members are a mix of patients and medical professionals. Yeah,
it's everything. It's anybody who touches healthcare in any way, John. They're members of the organization, which is just terrific.
And anybody can join. You can just go to the site and join.
Yeah, it's very inexpensive to join as an individual member. So we want everyone to join. And in fact, if you can't afford our modest dues, which are $50 a year or $300 for life, you can request financial aid and you're in. We want to be inclusive. That's really important. If you're a patient and you want to go to conferences like medical conferences, scientific conferences, whatever, we want to encourage you to do that. And so one of the things we have is that we have a travel award that we can offer so that you can defray the cost of your travel to these conferences.
Excellent. I want to get kind of the last thing to discuss, the elephant in the room, which is the potential pandemic that we're experiencing. And it could be the year from now, people will listen to this and they'll say, wait, what was that? But probably not. I mean, this is really a big deal. COVID-19, the coronavirus that has been spreading. And I know you and I talked about how when we had this discussion, one thing we could discuss is seeing that from the perspective of a primary care physician. But I think I'd like for you to talk about that as a primary care physician and how primary care physicians will be involved and so forth, but also from the perspective of participatory medicine and how participatory medicine may have a role in addressing this pandemic.
Yeah. So let's start with, in a sense, the participatory medicine side, right? And we know that knowledge is power, right? Francis Bacon said that, I think. Knowledge is power. And I think part of this is that people need to be informed. Everybody should be informed. Because, by the way, going back to that e-patient thing, I don't want e-patient to be a minority of the population. I want everyone to be an e-patient. And I want them all to be engaged and educated, enlightened, empowered. So part of that is getting access to information. And there is good information out there. And unfortunately, there's a lot of misinformation out there as well. My mother actually has emailed me a couple times saying, are you sure this virus wasn't developed in a Chinese bioterrorism lab? But these kind of things are circulating, right? And so people don't understand. So get reliable information. Get it from the Centers for Disease Control website. Get it from the World Health Organization. Get it from your own institution. You're probably working in a place. If you're affiliated with an academic institution, they all have policies in place. So look for reliable information. But I think, for me as a primary care doctor, one of the things that is striking is it's making me, once again, and with vigor this time, it's making me question why we take care of people the way we do. So I've been in, as you know, as you heard, I've been working in technology for many years and in healthcare, and it's always been amazing to me that we get people to come to a medical center to get checked on for a 10-minute visit when we could easily do this remotely. We have the technology to do this. Now, today, we don't get paid for that in the same way. But if you think about the number of patients that we see in the office that we could take care of remotely in some way, it's astounding. And we've got to think about this, because we're talking about limited resources, which we've always had, but it's even more so now, limited resources in healthcare organizations and physicians and nurses and so on. And we have people coming in for things that they don't need to come in for. So they're exposing themselves to a risk. So I've never been a fan of seeing people in the office we don't need to see, but again, that's the way we get paid. We don't have, or at least in our institution, we haven't deployed the technology to do things differently yet. It's not that the technologies don't exist.
We're using it right now.
Yeah, we are. Exactly. We're using it right now to do this. Right. So there's a lot that I can do this way to take care of you. I can do stuff over the phone and text as well. But now that I can see you, we can actually do other things. And if I had you plug in a remote stethoscope, I could have your wife put the stethoscope on your back and listen to your breathing. We could do a lot that way. And when I was working for Cisco, we did this all the time. This is what we should be doing. So personally, we're seeing a lot of people with colds, and in our practice, we're trying to, triage them more effectively so they're not filling up the office. And by the way, every practice loves to see patients with colds. Why? Because they get paid. Right? It's an easy visit. So let's bring the patients in with colds. But now what we're doing is we're realizing, we have a limited number of appointment slots, and we're exposing people to risk. So, personally, I've done something which is not necessarily condoned by my practice. I went through my schedule. So I'm in Boston, right? I went through my schedule of patients for the next month. And I made a list of everybody who's about 69 and over. And I've asked my medical assistant, who are scheduled for routine visits, I'm sorry. And I asked my medical assistant, my assistants to contact these patients and offer them to reschedule and push those appointments 2 or 3 months out. Unless it's an urgent visit, then I think we should be doing that, because these patients are at risk. So that's what I've done. I've been reading reports from other places in the world. Italy, I was just reading today a Twitter stream from a physician in Italy who's saying, they have such demand for medical services there that they're like recruiting orthopedists to go take care of patients with respiratory problems. Yeah. And that's just crazy, right? We shouldn't be doing that. Nothing against my orthopedic friends, but it's not what they're trained for, right? You don't want me to be taking care of a broken bone most of the time, or a hip replacement. So we've got to be smarter about the way we take care of patients. We got to keep people out of the hospital. We've got to just be smart about this epidemic in general. And I'm sure that things are going to get worse in the U.S. It's going to get more stress for our healthcare system. And God knows what we're going to do in parts of the country where, you were talking about, where you can't find a physician for 100 miles.
Yeah. We're using a platform right now called Zoom, which allows us to see each other and talk to each other. And I imagine that, there are degrees of severity of COVID-19, and some cases are so severe that a person might need to be hospitalized. And I assume that you could do triage via this kind of interface, right?
That's right. You could certainly do that. And by the way, one other thing that I think is important, kind of a couple of things I want to know from you, and you should know as an empowered patient. I want to know, are you having any respiratory symptoms? Are you having shortness of breath? Are you having a severe cough? Are you having a fever? The number of people who don't have a thermometer at home is just striking to me. But that's an important data point for us. So anyhow, those are the kind of things that I'd like to know. And I also want to know your travel history, of course. I want to know where you've been. There you go. Now that's not only a thermometer, but it's an old school thermometer with mercury in it.
Yeah, exactly.
I get my mercury from my tuna, John.
Really?
Thermometer.
You put tuna under your arm?
I do.
And if it starts baking, you got a fever.
Well, it turns red. It's pretty good.
Okay, we're just being silly now. Thank you, Danny. This has been an excellent discussion. Would like to do a follow-up sometime and talk more about participatory medicine, especially, and maybe bring in our friend Dave, e-patient Dave.
Sure. We have the technology.
Learn more about Dr. Sands at drdannysands.com. You can stay in touch with Plutopia at plutopia.io. On Facebook, look for @Plutopia News. On Twitter, it's @Plutopia. With John Lebkowski, I'm Scoop Sweeney. This is the Plutopia News Network, 20 minutes into the future.